Hi everybody, my name is Aditya. Thank you for having me here today. Today's talk is on thoracolumbar MRI in 10 minutes. Like all orthopedic surgeons, we can't wait and get things done quickly. So today's session is called Das Ka Dam, and we'll be talking about 10 different things that I find would be useful for all of you during reading MRI of the spine. The first thing that's important for all of you to realize is the sequences that we use. The common sequences are the T1, the T2, and the stir sequences. T1 weighted images demonstrate fluid as being dark and fat as being bright. So you will notice that in these cases, the disc is darker than the vertebral body. The next thing that you will see is the T2 weighted image. Here, fluid is bright and fat is also bright. But in this case, the disc tends to be brighter than the vertebral body. And then finally, the stir images. These are the images that we use to look for bone edema and for soft tissue swelling. And these are particularly important because they show fat and bone marrow to be dark, but the disc fluid to be bright. How do we use this? We use this when we're looking at marrow edema and marrow signal abnormalities. So you can see in this patient with leukemia how that contrast between the disc and the vertebral body. The disc and vertebral body are equally bright or dark in this case. In this case, you can see again the differentiation between disc and vertebral body is lost. And in this case, again, you can see the differentiation between disc and vertebral body is lost. And when we see this, this is something we could easily blow by and miss. And I think it's very important that all of you look at this because this is where you could really make a difference. Moving on to the end plate changes. We're all familiar with fatty end plate changes, which will typically be bright on T1 and T2 weighted images. Sclerotic end plate changes, which will be dark on T1 and T2 weighted images. And then end plate fractures, where you can see edema and a little bit of end plate irregularity at the end plates. We have Schmall's nodes. Occasionally, we may see Schmall's nodes where you can see that there is edema around them. So these are acutely exacerbated Schmall's nodes. We can have situations where we have seronegative spondyloarthropathy. So if you see Schmall's nodes, always look very carefully at the posterior end plates. If you see edema or you see bright T1 and T2 signal, which is fatty metaplasia at the vertebral end plates, you must think of seronegative spondyloarthropathy. And another problem that often comes up is infection. And in this case, if you see end plate edema or end plate edematous changes, look for an element of soft tissue adjacent to it, in which case this could be infection. In talking about osteoporotic versus malignant fractures, we're going to look at a few quick things. Remember that the normal vertebral body is a box that is stuffed with solid material. An osteoporotic one is an empty cardboard box, whereas a malignant vertebral body is one that is stuffed with styrofoam, if you will. So typically osteoporotic fractures would happen at multiple contiguous levels, whereas malignant fractures would happen based on the degree of involvement of the vertebral body. Which comes to the next point, that the osteoporotic vertebral body will typically contain fat, whereas the malignant vertebral body would have lost a lot of fat. And then when it comes to compression fractures, you can look at the involvement of the posterior elements, which would be more with soft tissue in the malignancy, but more with fracture in the benign case. And then the paraspinal soft tissue component tends to be more anterior with compression fractures, whereas with vertebral lesions, it tends to be more involving the entire vertebral body. So let's look at some examples. If you see a fracture line that's very nice, and you see a geometric looking retropulse fragment, then that is more likely to be, that is your best sign of an osteoporotic fracture. On the other hand, if you see a convex expanded looking vertebral body, then that is more likely to be a malignant fracture. Here you can see an example of contiguous fractures in somebody with osteoporosis, and here you can see fractures and a lesion that are far apart from each other in somebody with myeloma. We can see with the osteoporotic fractures that there is a lot of spared fatty signal, whereas when we have patients who have malignant fractures, you can see that there's no fat left in the vertebral body, and that's because the vertebral body was completely involved by the tumor. When it comes to involvement of the soft tissue, the posterior elements, you can see it's more sort of fracture-like and geometric compression. Whereas when you see this with a malignant lesion, you can see it's more soft tissue that's tracking all the way around and involving the entire vertebral body. The next issue that we come to deal with is TB versus pyogenic. And this is an important factor where we look at things which we come to in practice. And the important things to remember here are that if we see multiple vertebral body involvement, then that's more likely TB. If we see a smooth, well-defined paravertebral collection, that tends to be TB. And if we see subligamentous extension of disease over multiple levels, then that tends to be TB. If you see multiple vertebral body involvement, that tends to be TB. On the other hand, if you see one or two vertebral bodies, that's more likely to be pyogenic. If you see ill-defined soft tissue, that's more likely to be pyogenic. So this would be the common differentiators from TB versus pyogenic. Also in pyogenic, you would tend to see more disc involvement, whereas TB tends to involve the vertebral end plates more than the disc itself. We're pretty familiar with looking at discs. I think most of you are familiar with looking at central discs, at paracentral discs, at lateral recessed discs. I think some of the areas where we notice that people tend to miss discs are sort of more towards the periphery. So if you think about things that are far lateral discs, remember to look on the axial images for these far lateral discs. Also to remember to look at the sagittal images for sequestered discs, because when they give you axial images, they're usually right around the disc level, and the sequestered disc may be sitting somewhere in between. So you could miss that easily. Another area that is important for us to look at is recurrent discs and fibrosis. So if we think about somebody who has a recurrent disc, we give contrast. In contrast, what you end up seeing, you see diffuse enhancement of the perineural fibrosis, and you can see this small little non-enhancing nerve root with all the epidural fibrosis around it. In the case of a recurrent disc, you'll see a rim of surrounding and a peripheral enhancement in the disc and the central dark area. So this looks more like a donut, whereas this just looks more like sort of a panda sign, if you will, with the big nose and the two eyes here. Other things that can mimic discs, remember to think of textuloma. So if you have a foreign body or you have a gauze piece left behind, and then sometimes gas can also give that appearance. Facet arthrosis is something that, again, we tend to look at very carefully with mild, moderate, and advanced. T1 weighted images can help us show the bony components a little bit better. The presence or absence of perifacet edema can be important, and sagittal images are always good to look at facets. But I think the important thing is here when we look at perifacet cysts, and an example that I'm going to show you now is one that I come across not very infrequently, which is where when you look at the T2 image, you can see this, which looks very much like a cyst. But when you see the T1 weighted images, you also see something that looks like a cyst. And typically a fluid containing structure on a T1 weighted image should be dark and not bright. So this is bright on both T1 and T2 weighted images. And hence this is a classic example of a large osteophyte. And on the fat suppressed images, you'll see it doesn't have fluid signal. And here you can see it nicely on the sagittal image here as well. Moving on from the facets to canal stenosis, I think we're aware of the usual contributors of disc, ligamentum, facet hypertrophy, and facet arthrosis. But I'd like to take a moment to remind you to look for short pedicles on the sagittal images, which could lead to developmental canal narrowing. And then also to look carefully in some cases where you can see canal narrowing on account of a lot of prominence of the epidural fat. And this is epidural lipomatosis, which is another thing that you should look out for. The last thing we'll talk about is foraminal stenosis. And the big thing that I would want to drive home here is really that when you're looking at the foramen, many of you look at just the axial images. I would encourage you to look at the sagittal images so you can see here the nerve root and the foramen very nicely. And as you move towards the midline, you can see here how there is extensive foraminal narrowing at the foraminal entrance. And this is something that you can see very nicely on sagittal images, which you might miss easily on axial images. So with that, I'm going to sort of move on to a summary slide and talk about some of the things that we've discussed. We've talked about some imaging sequences. I hope you've understood the importance of T1, T2, and stir images and telling the difference. We've talked about diffuse marrow disease. Remember to look at the vertebral bodies and the discs and remember their normal ratios on different imaging sequences. We talked about vertebral end plate changes from degenerative changes to fractures, Schmall's nodes, inflammatory arthropathy, and infection. We talked about malignant versus osteoporotic fractures and this analogy of empty and filled cardboard boxes. We talked about differentiating between TB and pyogenic disease. We talked about disc disease and remembering to look at the sagittal and far lateral areas which are easily missed. We looked at fibrosis and enhancement as well as recurrent discs. We looked at facet arthropathy and I showed you an example of how you might mistake a facet cyst and a facet osteophyte. And I think that's helpful because when we do procedures for facet cysts, they're very different from the ones we do for osteophytes. We looked at beyond normal causes of canal stenosis. And finally, we looked at foraminal stenosis and sagittal images. So with that, I thank you for your time, and I'll end.